Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Behind the Knife wants you. Yes, you. We are officially looking for our next class of BTK fellows. We need creative residents heading into their research years who are ready to build the next generation of surgical education content. You'll get mentorship, access to great resources, and a global platform to display your work. Applications open in early spring with more information to follow. Dominate the day.
Hello, and welcome to the new Behind the Knife mini-series on the Operative Standards for Cancer Surgery Manuals, developed through the American College of Surgeons Cancer Research Programs. Operative Standards for Cancer Surgery, Volumes 1, 2, and 3, offer concrete, evidence-based recommendations on cancer surgery techniques critical to achieving optimal outcomes. These standards cover 15 distinct disease sites, with standards for additional disease sites currently in progress, and select recommendations have been incorporated into the Operative Standards or incorporated into the 2020 Commission on Cancer Accreditation Standards. My name is Jack Sample, and I'm a surgical resident at Mayo Clinic Rochester and a member of the Education Committee for the Cancer Surgery Standards Programs. And I'm joined by Dr. Tracy Wang and Dr. Vladmir Neychev, and along with other members of our committee, we are launching this new mini-series to help spread the word about the operative standards and to discuss each of the requirements and rationale. Today, we're going to be discussing one of the operative standards for thyroid cancer. To help with this discussion, today we're lucky enough to be joined by experts in the field of endocrine surgery, Dr. Elizabeth Grubbs and Dr. David Hughes. Dr. Grubbs is a professor of surgical oncology at MD Anderson, where she specializes in thyroid, parathyroid, and adrenal gland cancer. And Dr. Hughes is a clinical associate professor at the University of Michigan and a board-certified endocrine surgeon specializing in the management of thyroid, parathyroid, and adrenal gland disorders. Dr. Grubbs and Dr. Hughes, thank you so much for joining us. The Operative Standards for Thyroid Cancer were published in the second volume of the Operative Standards for Cancer Surgery. The thyroid section was primarily focused on the preoperative and intraoperative aspects of the evaluation and treatment of patients with biopsy-proven papillary thyroid carcinoma, or PTC, greater than or equal to 1 centimeter. This included critical technical elements for oncologic components of thyroid cancer surgery and recommendations for documentation in the operative report using synoptic format. In this section, important aspects of PTC management are highlighted, including modifications to the AJCC cancer staging system, the development of a recurrent risk stratification system, and preoperative elements used to guide surgical planning and management. This section also covers the critical technical elements when performing a thyroidectomy for PTC, including preservation of the parathyroid glands and the management of recurrent laryngeal nerve, as well as how to perform both a central and lateral compartment dissection. The key questions for this section also focused on the discussion and summarization of data surrounding total thyroidectomy and thyroid lobectomy for the treatment of low-risk PTC and indications for central compartment lymph node dissection. For the sake of today's Behind the Knife podcast episode, we'll be focusing on the decision-making regarding the extent of initial thyroidectomy. So we'll start with the first question for Dr. Grubbs, and I can personally attest that this is an area of confusion for surgical trainees, whether preparing for endocrine surgical rotations or when studying for the APSITE every year. The updated guidelines recommend that either lobectomy or total thyroidectomy are acceptable for PTC tumors 1 to 4 centimeters without extrathyroidal extension or lymph node metastasis. In your practice, what are key considerations you make during the preoperative evaluation of a patient with PTC that may influence you towards a thyroid lobectomy versus total thyroidectomy?
So thanks, Jack, so much, and really happy to be here and be part of this important discussion. So low versus total for a thyroid cancer less than 4 centimeters. And you're right, it can be confusing because the data really says that for many cancers that are low risk otherwise, a lobectomy or a total thyroidectomy is appropriate. But I want to say the key word there being low risk. And there are some things that you understand preoperatively to help you know whether it truly is going to be more acting like a low risk cancer versus one that has a higher risk for recurrence and therefore probably deserves a more complete operation in the form of a total thyroidectomy. So what can you use preoperatively to help you make that decision? Well, when the person walks in the door, you are going to talk to them, elicit some symptoms that are important that key us into do we have concerns? And then you're going to do some preoperative studies that are going to help you as well determine that.
And Dr. Grubbs, if I may, really quick, how may someone define one of these lesions as low risk?
One of the things that we think about when we think about low risk is that the tumor itself, no matter what the size it is, has not left the thyroid and started to invade other surrounding structures. Things like we think a lot about that recurrent laryngeal nerve that is right next to the thyroid and intimately involved with it, as all of us that do thyroid cancer know only too well. We think about the trachea. We think a little bit about the esophagus, even though that's often less involved. And then you also think about anteriorly with those strap muscles. Like these are all the areas that surround the thyroid and that a thyroid tumor could choose to grow into.
Dr. Grubbs, you just mentioned some features of a PTC tumor that are more consistent with an invasive lesion. And these are things that we may observe on preoperative ultrasound or in the OR. But how can we assess a patient's symptoms to determine if they have a low-risk cancer based on their clinical presentation?
So when a person comes in, we ask them things about their voice. Have they noticed changes in voice? Have they had change in the caliber? Do they experience more hoarseness? We ask them about their swallowing. Really, the key for us, the big one is pain on swallowing. That gives you a real concern of could there be involvement with full thickness of the esophagus. If I have a patient that truly has that, I'm going to have a little bit more concerned that there could be some of that invasion that is happening. And that would, no matter what the size of the nodule, even if it's under 4 centimeters, I would be concerned it could be higher risk. And I wouldn't want to put it in that low risk category and say that we could just do a lobe. We also want to feel that neck and we want to feel not just the thyroid itself, because sometimes we can feel a thyroid and we can feel a little cancer and it's nice and mobile and it moves when they swallow and you're like, oh, this guy's not stuck to anything. And sometimes you feel a neck and that it's a very firm, very kind of soft in feeling. And that gives you a higher concern that it maybe has started to grow roots around it. So that helps you. And then the other thing that you can do is feel for lymph nodes. Sometimes in the central neck, even though that can be a little bit harder because that thyroid's in the way, and certainly in the lateral neck. If you have concerning palpable lymph nodes, that's something that is also going to get your concern up that there could be metastatic lymph nodes that are large enough that I can feel them with my hands. Those are things that are probably leaving the realm of low risk thyroid cancer where you could consider doing a lobe versus a total thyroidectomy, and you really wouldn't make that choice then.
Great. So you have a patient in clinic and you've elicited your history and performed a physical exam and are able to palpate a mass on the left side of their neck. What imaging studies are you going to use next for your preoperative workup?
Fortunately, we have other studies, imaging studies that can help us. Our go-to is always going to be the ultrasound. And so that's a great preoperative modality that we have. And I would say that really we like ultrasound as the go-to imaging modality to start with. In that setting, we're not just going to look at the thyroid, but we're going to look at the thyroid and the lymph node basins, both in the central neck, what we can see, and in the lateral neck. That's a really important preoperative evaluation that we talk a lot about in the operative standards. With the thyroid yourself, with the ultrasound, you can start to get an idea whether you think that there is involvement of the surrounding structures. You can't see a good plane between the trachea. You can't see a plane anteriorly with the strap muscles. We'll talk a little bit about the strap muscles later on and how important we think those are. But you can start to get an idea. Do you think that this tumor is actually invading outside of the thyroid? Same with lymph nodes. You can look for concerning metastatic lymph nodes within the ultrasound. This is really going to be helpful in those lateral necks where ultrasound is a beautiful way to see whether there are concerning lymph nodes that are there. At their lymph nodes that are concerning for metastasis, we would usually talk about interrogating those with a biopsy, along with getting a biopsy of the primary tumor itself. And then in the central neck, you may be able to see metastatic nodes. I always talk about it with patients that sometimes that thyroid makes a little bit of a blind spot, so you don't see it as well, but look for it.
Today's episode of the Behind the Knife podcast is brought to you by our presenting sponsor, Gore Medical Products Division. When it comes to ventral hernia repair in high BMI and comorbid patients, strength matters. Gore Cinecore biomaterial is a permanent mesh that is built like a lightweight, with the strength of a heavyweight and has 0 reported mesh fractures. With a less than 1% recurrence rate in ventral hernia working group grade 1 and 2 patients and a low rate of infection, Cinecore is designed to support your complex ventral hernia repairs. Visit goremedical.com/btkpod to learn more and ask your Gore representative about sizing and availability. Gore is Cinecore biomaterial, no compromise for your high BMI and comorbid patients. Intended for U.S. audiences only, Gore is a financial sponsor of this podcast, which has been independently developed by the presenters and does not constitute medical advice from Gore. Always consult the instructions for use prior to using any medical device.
Yeah, Dr. Grubbs, what are your thoughts on the role of a CT scan in your preoperative workup? I've read things like CT imaging should be deferred or not be used in the preoperative setting because of the potential future use of radioactive iodine.
I also would say that if on my imaging, both symptoms that patients have and the imaging that I find in ultrasound sometimes prompts me to get additional imaging in terms of a CT scan, because that can be additive in those settings. Sometimes I think the CT scan does a better job of helping describe whether there's more infiltration, especially of the trachea and also the esophagus. So if an individual either has an enlarged cancer that looks concerning on ultrasound, I'll get more information from the CT. Or if that patient came in and had really had hoarseness or had that really firm nodule, sometimes that's when I'll also get the CT as well, because I think that's additive to the ultrasound. So that's the imaging part that really helps me understand that if for me, if there's lateral metastatic disease and a lot of times if there's central metastatic disease, or if there's real infiltration into the trachea or the esophagus, that's when I know this is going to be a more advanced cancer, and that lobectomy is less of an option for me.
Yeah, Dr. Grubbs, I completely agree. That ultrasound is so key. And if you have the capacity to do your own ultrasound as a surgeon, I find that very, very helpful. It helps you kind of map out the lymph nodes that are positive, which lymph node basins you need to dissect. You did mention the central versus the lateral neck. Sometimes that can be a little confusing. So the central neck lymph nodes are typically the level 6 lymph nodes. Those are the lymph nodes that go from the hyoid bone cranially down to where the innominate artery crosses the front of the trachea caudally. The lateral borders are the common carotid arteries, and then the posterior border is going to be that prevertebral fascia over the top of the spine. And you want to make sure you remove all those if there are metastatic lymph nodes present in that ipsilateral side of the tumor. Most patients, if they have lateral neck lymph nodes that are involved, are also going to have central neck lymph nodes involved on that same side. So if you're ever doing a lateral neck dissection for metastatic lymph nodes, make sure you get that central neck on that same side while you're removing that tumor, obviously, in the thyroid gland.
So I agree with all of that. And I think also when we're going back to this idea of preoperative evaluation and trying to decide when you can do a lobe versus a total thyroid, I think the other things that I think about besides, potential invasion outside of the thyroid and lymph node involvement, which makes me think this is going to be potentially more a thyroid cancer that's higher risk for recurrence, where I think a total thyroidectomy, we start to think along those lines, because the idea of potential radioactive iodine and using that might come into the discussion. I think the other things that I think about is, okay, what about if I was potentially going to do a lobectomy, what's in that other lobe? Are there things within that other lobe that make me say that continuing to watch it would not be the best idea? Do I need to biopsy anything in that other lobe that it doesn't have the known cancer within it to rule that out? The history of the patient. Do they have a history of radiation to the neck? Usually we think about that history, several decades before that would really increase your risk of having a thyroid cancer. So, asking if they have a history of ionizing radiation, once in a while, about once every 8 years, I'll get someone that was downwind of Chernobyl. So it's always worth keeping that in the back of your mind. But more, you're also thinking about radiation from either an older generation might have it from they were radiated as a child, when they were a baby, when they had the thymus radiated. Radiation for acne was done, and that would be people more in their 50s to 60s to 70s now. And then radiation for other head and neck tumors or any lymphomas that would have involved the neck as well. If they have that, that's an increased environmental risk for having thyroid cancer. So you might consider saying, well, because of this exposure, you might consider removing the entire thyroid.
Yeah, I think when getting these patients' histories, we often think about those exposures you mentioned, such as childhood radiation or environmental. But at least speaking for myself here, we often overlook family history. So can you speak a little bit more about how this may influence your decision making when considering a thyroid lobectomy versus a total thyroidectomy for PTC?
Family history is an interesting one as well. We talk about with well-differentiated thyroid cancer, which are your papillary thyroid cancers, follicular, and your oncocytic, that there can be a family component to these non-medullary thyroid cancers. And we usually talk about that as if you have at least, what are we calling it, 3 first-degree relatives that also have one of these thyroid cancers, then you might consider a total thyroidectomy in that setting, because we think you are at increased risk of having a hereditary component to it, and that means potentially multifocal. And then I think the last really, really important thing is, what does the patient want? And that's a huge discussion that we have. There are some patients that I know Dave can attest as well that never want to even consider the risk of another operation, or considering that they could have a cancer within the remaining lobe, and they want a total thyroidectomy because their quality of life will be challenged by just even the thought of that. And I kind of put them in what I call my maximalist group, and that's okay. For them, if I can do this safely and a total thyroidectomy is right for them, we have that discussion. Much more likely in my practice is individuals that are more minimalist and are like, what is the minimal amount that I can do for this and have the same outcome? And for them, they really enjoy the thought. Enjoy might be a strong word. They really like the idea of being able to keep some of their own thyroid and having their own endogenous thyroid hormone.
So one thing I usually tell my residents when they're trying to decide if they need a total or a lobe is try to think about the end. So if they're going to need radioactive iodine therapy, they should probably get a total thyroidectomy. So think about the indications for radioactive iodine. It's lymph node metastasis, extrathyroidal extension, tumor bigger than 4 centimeters. That's a little bit debatable. Or if they have some kind of high risk variant of papillary thyroid cancer, you'll only be able to figure that on the final pathology. But if you think they're going to need radioactive iodine based on their initial clinical presentation, you should do a total thyroidectomy.
One very quick remark before we move on, if you allow me. It's many patients, specifically female, have underlying sometimes subclinical Hashimoto, and it's very unlikely, at least you, the experts, you'll tell us, but it's very unlikely that we can guarantee that even successful and pathologic proven low-risk papillary thyroid cancer may render them pill independent. That's the only reason we'll leave thyroid tissue behind. There is no other reason. As Dr. Grubbs said, you will wonder, do you biopsy something? Who do you follow? Is there cancer there, which is not unheard of? Even in smaller nodules, you never know. But the Hashimoto thyroiditis, especially in women over age of 50, is very prevalent. Just a quick note.
That's a really good point. We talk about this in terms of, when we talk about, I know we're not talking about this today, but observing small thyroid cancers, and one of the contraindications for observing is when you've got thyroiditis and you don't feel like you have a good understanding of visualizing, the
Exactly.
modules within the thyroid. And so I think that's something you can talk to patients about, do we feel like that we're really getting a good view of that contralateral lobe? I think the other thing you bring up, which is a really good point, is patient expectation about are they going to, sometimes we talk about doing a lobectomy. If all things are equal, it's a low risk thyroid cancer. You're not planning on giving radioactive iodine. If I have half my thyroid in place, then I won't need to be on thyroid hormone replacement, right? And the challenge there is obviously sometimes that we give additional thyroid therapy in the form of thyroid hormone suppression as, treatment for the cancer. And so I always am sure to remind patients that just because we only take out a lobe doesn't mean we're not going to recommend thyroid hormone. But I do find that there is still value to having sometimes their own thyroid hormone, even if we're going to supplement it, than being completely thyroid hormone dependent. And so those are the, some of the, especially with my young women, and I know the studies haven't really panned out to show us very well about quality of life with lobe and total, but just having done this, a couple of years, it's like you start to have these observations.
We somewhat covered it. Dr. Grubbs and Hughes both mentioned that there have been several studies now, so increasing volume information and studies that show that there is really no significant statistical difference that will, render disease-free survival benefit between thyroid lobectomy versus total thyroidectomy for low-risk papillary cancer. But I wanted to ask you guys, let's say, Dr. Hughes, let's say that you are operating on a 45 years old woman with 2.5 centimeter papillary thyroid cancer that has been biopsy proven. What would, and you are planning for thyroid lobectomy, what would be the intraoperative finding, maybe actively looking for them, or just that will appear, that will change your decision making?
Conversion from a lobectomy to either a total thyroidectomy.
Correct.
So then either with or without a lymph node dissection. Yeah.
Yes.
Yeah. I tried. And the best thing you can do is avoid surprises. Make sure you get good imaging before the surgery. Make sure that ultrasound can really evaluate those things. If you do get in there and you see some extrathyroidal extension of that tumor, if it's anterior and just into the strap muscles, most of the time you can just remove a small island of the strap muscles along with the tumor and be able to get a negative margin. There's a few studies that show that the strap muscle invasion really doesn't necessarily equate to worse outcomes. That's a little bit different if it's a posterior extension and it's growing into either the esophagus, the trachea, or the recurrent laryngeal nerve. Then you want to obviously try to preserve those structures as much as possible. If you have a functional recurrent nerve prior to surgery, and there's invasion of that tumor into the nerve, you should do everything you possibly can to try to preserve function of that nerve, even if it requires leaving a microscopically positive margin on the nerve. If the nerve is already out prior to surgery and there is extrathyroidal extension into that nerve, sacrificing the nerve to get a negative margin is perfectly adequate. So I think that extrathyroidal extension posteriorly is a more likely surprise because the ultrasound, there could be a blind spot caused by shadowing, and that's something that you won't know until you're in there with surgery. If you're leaving a positive margin on the nerve to preserve it, that patient probably would benefit from radioactive iodine and to convert to a total thyroidectomy for that patient. The cervical lymph nodes, you will see some central neck lymph nodes when you do a thyroid lobectomy or total thyroidectomy. Those lymph nodes will look abnormal. A lot of times they'll have some either cystic changes, they'll have a little bit of a balloon color to them, depending on what the primary tumor looks like. Using frozen sections has great, sensitivity for presence of lymph node metastasis. If you got lymph node metastasis in the central neck, especially if it's visible to the naked eye, you should probably convert to a total and then perform a formal central neck dissection, at least ipsilaterally, if not contralaterally, for a patient like that.
I agree completely. I think, the one thing that to pick up on what Dave was saying last, and, we often have the the thought process of what is the right amount of operating sometimes in this setting. And, I think in the setting where you have known collateral disease, a lot of times I will think to myself, I should do a bilateral central neck in this setting. But I also have to weigh this against what are the risks of doing that more aggressive central neck on the contralateral side from the primary cancer. And that's where I really kind of have to take stock, where I am in the case. Okay, how do my 4 parathyroids look? Right? If I feel that the ipsilateral side was that right side, and I just, well, let's blame the disease. It had nothing to do with the surgeon. Those 2 parathyroids look terrible. Couldn't have saved them. Not the best surgeon in the world. But if they don't look good, and I go to the other side, and I know that, and I don't have any, grossly concerning lymph nodes on that contralateral side, and I know I need to save a parathyroid, I might choose in this case, because those parathyroids I know that I have a higher chance of having hypoparathyroidism. If I hurt these last 2 remaining parathyroids, I may decide in this particular case to say I'm going to be less aggressive, versus if on that ipsilateral side was amazing, and again, now it's the surgeons who saved those parathyroids and they looked great, then I might be more aggressive on that contralateral side. So, you're constantly in this operation kind of recalibrating, where am I? There's always a fork in the road, and it's like, which way has more benefit? And sometimes, you have wiggle room that you can make some of those decisions. Sometimes you don't. Sometimes you have bilateral central neck, large nodal metastasis that you need to remove, and you're going to have to take more risk in terms of doing more dissection, which by definition puts those parathyroids at greater risk. But those are, conversations that you're had. Those are things that are case by case, that you just can't make grand observations that apply to everyone.
I think I in my practice I also do the same thing, like really weighing the risk intraoperatively and seeing, honestly, how the superior look, and if it's the lower parathyroids, like in the thyroidemic ligament, not always can see them actually. At least I not always identify them really clearly with lymph nodes surrounding them. So it's a really technically challenging part of the procedure.
Yeah, thanks, Dr. Grubbs and Dr. Hughes. If I can just chime in. So assuming you have a unifocal thyroid nodule, nothing contralateral, do you ever say, hey, there's a need to do a total thyroidectomy here? Does size play a role into it? Or, where are you in that camp, in that spectrum of making that decision right now?
Yeah, I think you've got a 4-centimeter cancer that's obviously inside the thyroid gland. Everything else looks completely normal. It is a patient decision, I think. I think it's important to counsel them that their outcomes will probably not be drastically different if you do a lobectomy or a total. Their life might be a little bit different. Needing a total, you're going to obviously have to take thyroid medication every day. The rates of needing thyroid medication after just a lobectomy vary pretty widely based on the patient factors, what TSH you treat with a thyroid medication versus not. But there's a significant risk that you need to take thyroid medication long-term anyway. The total thyroidectomy does expose both recurrent laryngeal nerves. It is going to slightly increase the risk of nerve injury. And obviously hypoparathyroidism only happens in total thyroidectomy. It doesn't happen if you do an initial lobectomy and they never had the other parathyroid glands disturbed. So going over all those things with the patient preoperatively, I think will help make the best decision for them.
I think we do know that there is information that the larger the cancer, the more concern there is for risk of recurrence. And so you might consider, doing in a more extensive operation. And so I will say that when I have a 3.8 centimeter thyroid cancer, it gives me a little bit of pause, right? And that's where having discussions with patients prior about about expectations and what their goals are is helpful. Again, if I've got a 30-year-old female who's very, very motivated to save her contralateral lobe and understands that we may be going back for additional surgery in the future with a completion. That's different than my 78-year-old or that's like, I never want that, like, do what you got to do, but this is it. You got one shot. So I think you kind of have to take some of that into consideration as well. Again, that 1 to 4 range is kind of a toughie, right? That's a big range for thyroid cancers. And I think that, they don't all fit into one bucket. And you do have to think, you do want to think through that. I think the other thing as well, and I didn't say this during the preoperative part, but a reminder, you're always in this as a partner with your endocrinologist usually. And so if you work with an endocrinologist that tends to like to, that is more RAI forward in how they treat their patients, you want to have those discussions with them before you operate, because what you don't want is the patient coming back to you and saying, Dr. Jones said you needed to take my other lobe out because they're definitely going to give RAI. Have that discussion ahead of time. Really understand with your clinical partners how you each work so that you can have some of that. And so there's not confusion with the patient after the fact. Better to go ahead and have all that discussion ahead of time.
Excellent. Dr. Grubbs and Dr. Hughes, thank you so much for joining us today and sharing your technical expertise surrounding the field of thyroid cancer surgery.
Thank you, guys. Appreciate it.
This is a really great discussion regarding the clinical questions that we often encounter, particularly for surgical trainees like myself. And I hope that, this discussion will help reinforce some of those really important evidence-driven oncologic considerations that we encounter.
Thank you,
Highly
Jack.
appreciate it.
If you're interested in learning more about the operative standards for cancer surgery, check out the Cancer Surgery Standards Program website, which will be linked in the show notes. Thank you again for joining us, and catch upcoming episodes in the coming months regarding more operative techniques for cancer surgery.
And dominate the day.
Dominate it, man.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.